About our actual experience, which has been going on now for 13 years. And I would like to thank all my colleagues at the Egyptian IVF Center, starting from the lab to my assistants and my secretary, because they all assisted me a lot in the last 2 months to collect all the data, and it is quite hard to follow up all of these patients. We know that the first human pregnancy using frozen sperms was reported as early as 1953. And the first pregnancy after ET of frozen embryos was in 1983. And egg freezing, the first pregnancy reported after egg freezing was in 1986. So it seems that it's been going on for a long time, but our experience has actually been in the last 10 years or so. And of course, the main change which happened was the technique of freezing. Shift from the slow freezing to the vitrification really improved the results of both embryo freezing and pregnancy rates from embryo freezing, as well as oocyte freezing using the vitrification techniques. So as mentioned by Professor Aboulghar Ramzi, the indications for oocyte cryopreservation are mainly to preserve the fertility, and this of course could be for cancer patients that might receive chemo or radiotherapy, or in family history of premature menopause, and these are young girls that come and are very anxious and they know that there is an issue in the family, or patients that are suffering from severe endometriosis will undergo multiple surgeries, and as mentioned by Professor Aboulghar, male factors, so male infertility with absent sperms, failure to collect, or unavailable partner, and this of course we were all met with in the last 2 to 3 years with the COVID pandemic. And of course, social freezing, and I will talk about all of this in detail. Just one slide on ovarian tissue cryopreservation, as mentioned by Professor Silber. It has been proven to be effective, especially in cancer patients that are going to receive chemo or radiotherapy. There are some concerns that cryopreserving the ovarian tissue might result in the return of the cancer or the tumor because of cancer cells, and it seems that it is a good technique with good results. But of course, it needs a very specialized team with very special training for how to actually take the ovarian tissue, how to cut it, how to freeze it, and then how to re-implant it and to produce actually mature eggs from this ovarian tissue. While egg freezing needs the experience of an IVF center with a regular experience. It's not for an IVF center that is performing embryo freezing and thawing. Egg freezing is not an issue. At the Egyptian IVF Center, we started around 2012. It took some time. We were trying on excess eggs that we had until we were sure that the vitrification really resulted in survival of the eggs. Going through the data, we have about 258 patients, probably more now, because we do it weekly, several patients, and this was about 295 cycles of egg freezing. Because many of the patients, as mentioned by the previous speaker, they do several trials because they want to collect the largest possible number of eggs to obtain the expected success rate. And we do trans-abdominal ovum pickup for young unmarried ladies that do not want to do it trans-vaginal. So we have done more than 125 cases of trans-abdominal ovum pickup, and we have not had any complications. One case of rectus muscle hematoma. Otherwise, they have all been safely past the procedure. The mean age of the patients around 35, the mean BMI 27. You can see that we've used all different protocols. I think when we started, we used both the long and the antagonist, but lately we have actually in all those aiming for egg freezing, we do the progesterone primed cycles with a very good compliance, because they are very short cycles and the patient doesn't have to go through this very long with multiple injections to produce those eggs. From these more than 250 patients, we had 26 cases that actually did thawing of their eggs, and 21 of them had embryo transfer from the frozen eggs in 23 embryo transfer cycles. And here are our results. The mean age of the patients, 34 years, the mean BMI, 30, a problem that we face, I think, all of us with our patients, especially challenging when we do transabdominal pickup. And the indications, one of them was a social, she came purely for social egg freezing, and the remaining cases were all cases where the male we had to go for a testicular biopsy, no sperms were found, the male received treatment for sometimes more than a year, and then came back with sperms available, so we did thawing of the eggs. Some of the cases, the husband was unavailable or was sick, was receiving treatment, and it was not possible to use his semen. The mean number of oocytes, 212, and the survival was about 90%. So when we thawed the eggs, we had more than 190 eggs that survived. 130 of them were injected because not all of them were mature. We have a fertilization rate of about 70%, and 7 of those resulted in live births. One of them was a stillbirth, but she actually reached 29 weeks, so she passed 28 weeks. So the 7 cases that got pregnant actually all had birth. We didn't have any case of miscarriage. Now, the cases that did not undergo embryo transfer, 2 of them were not injected because the oocytes were degenerated or were GVs. 2 were not fertilized, and 1 fertilized but arrested at 2 p.m. Now, the low fertilization rate could be explained by the majority of these cases were TISA cases, very severe male factor cases, and also the percentage of eggs that might not be used, because especially in the beginning of our program, we used to freeze all, even GVs and M1s. I think we are starting to reconsider now not to do that. There was, in the beginning, a lot of fear and inexperience, and we have experience with in vitro maturation, so we have experience with GVs that we wait for the next day and they are actually injected. And some of the cancer patients, the argument is freeze everything she produces because she's a cancer patient. But I think that we are starting to change this, and especially when I went through the results, I actually discussed this with our lab, and we are going to reconsider that. I'll just give you the example of the social egg freezing case that actually did thawing. She was a lady unmarried. She came when she was 39 years and 3 months. She wished for egg freezing because she was worried about her age. We used the antagonist protocol. She produced 10 oocytes and 9 of them were frozen. She came back after 1.5 years, so she was now over 40. She was married, and we did thawing of the 9 frozen eggs. 5 of them survived. We thawed all of them, we injected all of them, and all of them were fertilized. We transferred in the first cycle 3 embryos, and she got pregnant and delivered a healthy a female baby. The second trial, she still had 2 embryos frozen. We transferred them, but unfortunately she did not get pregnant, but she has a live, one living female. The cancer patients, they were about 12 cases, aged from 20 to 35. The mean number of oocytes produced by them were about 84 frozen eggs. We didn't do any embryo transfer, and unfortunately we didn't do any follow-up. I would be very scared to call these patients. They were 4 breast cancer patients, 4 ovarian cancer patients, 1 lymphoma, and I actually know that she passed away, and 1 colon cancer, 1 tongue cancer, and 1 bone marrow transplantation case. So actually the number of cancer patients are not that many, and maybe this shows that we need more awareness and more communication between us and our colleagues, the oncologists, about the importance of referring these young girls before they start the chemo or the radio. Now, we do trans-abdominal ovum pickup for cases with that do not wish to do it transvaginal, and this is how we do it. I just put a short video. We use the vaginal probe actually because it gives more depth, and the same needle guide and the same needle, and you can see the needle is quite clear in the follicle. I'll show you the video one more time. You can see the needle is very clear in the follicle using this technique. Of course, the challenge is the abdominal wall and the BMI, which is it is quite difficult. You can see the needle is quite clear. And again, you can see the follicle with the needle in the follicle, and the needle guide, the line on the screen, it is quite clear, and this is the technique we use. And I really want to congratulate and thank our very, very clever gynecologist at the Egyptian IVF Center who thought of this idea and who do it weekly and really have a very high experience with it now, and alhamdulillah, the complication is very low. Now, what do we do with our patients? How do we manage the patients, especially coming for social egg freezing? Number one, we have a specialized team to receive them because they come and they are very, very anxious. They are very socially, it is very difficult for them being unmarried to come to an IVF center. So we have a special team that deals with them from the reception till she meets the doctor. We give them a very gentle counseling. We feel how tense and anxious they are. We do the routine counseling and the routine history taking, pre-cycle assessment. We do, if they are unmarried, we do transrectal ultrasound for all of them, AMH, TSH, prolactin, routine labs, history taking, especially if she's had any previous surgeries or any medical history. And we give them a detailed explanation of what is going to happen. And as I mentioned recently, we prefer the progesterone primed protocol because it's very quick, easy. The incidence of OHSS is much lower, and she has a quick return of the ovary size to the pre-cycle size, minimal pain and distension with the ovulation induction. We explain to her that there will be minimal to moderate pain after the ovum pickup. We do give antibiotics. If we're going to do abdominal pickup, we give cover of antibiotics for 1 week, and we reassure the patient and explain to her that the abdominal pickup is just a needle prick, it's not a surgery, it's not a suture, we don't suture, and therefore we reassure. Now, one of the most important things that we do in this counseling, actually the first meeting with the patient, is to explain to her the expected success rate. If she uses those eggs after a year or 2 or even 10 years, what is the expected success rate? And we explain to her that it will be calculated depending on her age, her ovarian reserve at the time of freezing of the eggs based on our results. And I think this is very important. She should not have, if she's coming to freeze her eggs and she's 40, she should not expect to have a pregnancy rate of 30 and 40% after thawing these eggs after a year or 2. And we should also take into account the survival rate of these eggs, because some of them actually do degenerate. And of course, as mentioned by Professor Aboulghar Ramzi, the number of oocytes that she needs to ensure a successful pregnancy, again, is calculated from her age and from the literature that is published. We know that vitrification definitely gives a higher live birth rate than slow freezing. Now, the slogan that the younger the better is not necessarily agreed on, but probably it is better to be less than 35 years when freezing the eggs. But the problem is, if you freeze the earlier or the younger you are freezing, the less probability is that you will use them, because this means that they will be frozen for a large number of years, like 10, 15 years. And so it seems from the literature that the early to the mid-30s is probably the best timing, of course, except in patients that have high risk for premature menopause. Rienzi, one of the very renowned embryologists, recommends at least 8 oocytes for a reasonable success rate. And other authors mentioned the figure 20, that we need about 20 mature oocytes to have a reasonable live birth rate, which again will depend on her age. Safety, comparing vitrified wound oocytes to fresh oocyte cycles doesn't seem to affect the live birth rate, so it seems that from the literature that it gives the same live birth and ongoing pregnancy rate. Of course, the concerns for safety arise due to assumption that egg freezing might result in altered meiotic spindle integrity. However, it seems there is no difference in the incidence of congenital anomalies in children born after oocyte freezing or fresh eggs, and no significant difference in the aneuploidy rate in embryos obtained from fresh eggs or frozen eggs. And similarly, all the obstetrical complications, it doesn't seem to be higher in cases where we have used frozen eggs. What are the risks, the drawbacks of oocyte freezing? The patient needs to undergo controlled ovarian hyperstimulation and surgical ovum pickup, which might be transabdominal with the risks. Of course, we do discuss with the patient that maybe it is safer to do it transvaginal, especially if we have a very low number of eggs, but of course we leave this to the patients, it's up to her. If she's going to use those eggs, she must undergo an ICSI procedure. She cannot get pregnant spontaneously, and unfortunately, it might give her a false sense of security that she has eggs that are frozen, but she really doesn't know when she will use them or what the success rate will be. And of course, there is a theoretical risk of infectious disease transmission with the open vitrification methods. What are the limitations? The number of women who actually utilize their frozen oocytes is low. Of course, there are several reasons for that. I think in our community, the main reason is still the delay in marriage and the prospects, as Professor Aboulghar mentioned, of marrying the right person and a lot of other issues. We need to freeze a larger number of oocytes to actually have a reasonable live birth. And of course, the financial burden, absolutely. Going through the cycle, going through the medications, the cost of freezing and the yearly fees for freezing, and then she has to go through an IVF cycle. So unfortunately, the patient has to afford it, to think about it even. And that's why probably most of the cases are from the higher socioeconomic levels in our society. Just looking at the literature, the reported success rate or live birth rate in this large study, which included more than 400 transfers, they reached a live birth rate of about 39, while we had a live birth rate of 30%, bearing in mind that the majority of our cases that actually did thawing and injection were male factor cases, most of them testicular biopsy cases, so this could explain the difference, but I think 30% is a very reasonable live birth rate. What are our recommendations and views for the future? Definitely raise awareness among patients. The issue of a low AMH discovered accidentally is really scary. They come a lot, young girls and unmarried women coming. I don't know why they did the AMH, for a reason, and they are really very, very worried. Oocyte cryopreservation is available, and it has a reasonable pregnancy and live birth rate. In Egypt, based on our experience, we are able to offer transabdominal ovum pickup, which is very important for our unmarried population with minimal complications, but of course needs experience. Good survival and good fertilization rates are expected, especially in the younger patients. And finally, this group of patients, they really need psychological support. And what I feel after I have seen so many of those is that after they finish the first cycle, they are really much more relaxed. They can start to think rationally, and maybe then we can discuss if they need to do another trial or third trial to have the reasonable number for a reasonable pregnancy rate. I want to thank the team of the Egyptian IVF Center, all of them, from the consultants to the embryologists and my assistants and colleagues, and thank you very much.